So as I was saying, I have been working with the Maternal Mental Health Leadership Alliance to lead our perinatal mental health screening project. And we really wanted to get involved with screening because we know that that's kind of where the buck stops. That's people's entryway into the treatment pathway, figuring out what's going on with them and that sort of thing. So we just knew it was super important to do work in this space and make it so that every new mom, every new parent is being screened for perinatal mental health disorders, um, and that they're also being connected to resources, which is super, super important. Um, so let's see through. So let's just start with a little crash course on perinatal mental health disorders. I know many of you probably know a lot of this already, so I won't spend too much time talking about it. But when we say perinatal mental health disorders or perinatal mood disorders, maternal mental health disorders, these are all kind of interchangeable terms for a collection of mental health illnesses that can impact an individual in pregnancy or the postpartum period. And so we most often hear about postpartum depression as our main one, and that's likely the most prevalent. But we also have other conditions that are occurring, such as perinatal anxiety. That one's pretty common and pretty comorbid with depression. We have OCD, bipolar illness, post-traumatic stress disorder is a big one. I know many of you may have heard of the recent tragedy in Massachusetts, where a mother actually ended up, oh, excuse me, I think I mixed my examples. This is actually an example of postpartum psychosis, but a mother ended up taking the lives of her children and then shortly after attempting to take her own life. And this was because she was unable to find a successful treatment. So this is just one of the examples that proves the kind of importance of thinking and talking about perinatal mental health disorders, and figuring out how to connect people to resources. Some more information about these disorders. They're the most common complication of pregnancy and childbirth, impacting 1 in 5 individuals. And that number skyrockets to 1 in 3 in high risk groups. So some of those high risk groups include families that have had a child in the NICU. We know that taking care of a child who is not well can be very stressful. And so we see a lot higher rates in those populations, but we also see higher rates in individuals who are experiencing poverty, communities of color. So for example, Black women have higher rates of some of these disorders, and unfortunately, they are less likely to receive treatment for them. So many high risk groups. Another one is our military and service members. That's actually a project area that MMHLA is going to be working on a bit more in the coming years, just having more conversations about what mental health care looks like for our service members and making sure that they are receiving the care that they deserve. Some more information here. We know that 75% of individuals who are impacted by perinatal mental health disorders actually do not end up receiving treatment. So there's a pretty steep cliff between, people experiencing these conditions and perhaps being diagnosed and then not being able to access care on the other side of it. So we're really kind of focusing in on screening as our first kind of way to get at this problem. We just want to make sure that people are being identified, and that they are then being connected to services on the other side of things. So now that we've got that little background on perinatal mental health, I just want to speak more about the screening project in particular. So we started this project back in 2021, I believe. We brought together a small group of individuals to help us think through issues with screening and design a project to start making progress in this space. So some of the people we had involved, we had Adrian Griffin, who is the executive director of MMHLA. We also had, excuse me, let me just go back to my slides here. Sue Kendig of the National Association of Nurse Practitioners in Women's Health. Jennifer Payne, who is with the Marseille Society of North America, and Shanita Roach, who is CEO of a nonprofit called Shades of You, Shades of Me, which is focused on multicultural health. And we also worked in partnership with the March of Dimes to bring this project to life. So that was a really great experience. Obviously, they're a big name in the maternal child health space. So as I was saying, we got together in 2021 to pull together this project, and we really decided to focus on figuring out when screening for perinatal mental health disorders should happen. So we saw that there are different organizations in the maternal child health space that have recommendations for when screening should happen. So for example, ACOG, the American College of Obstetricians and Gynecologists, has some guidelines for their practitioners on when to screen. The American Academy of Pediatrics also has guidelines for when screening should happen at well child visits throughout the first year. But these recommendations were pretty siloed. They weren't really connected into one cohesive approach. So that's what we wanted to do, figure out one kind of singular timeline for when screening should occur. So we brought together a larger group of about 35 individuals from across maternal health space, mental health space, to do that work and put together this kind of ideal timeline of when screening should happen. And ultimately, unfortunately, I won't be able to show you the full framework or the timeline that we put together. But just to summarize, we ended up putting together a timeline that suggests 13 different screening interactions throughout pregnancy and the first full year postpartum. And so those screenings would ideally start as early in pregnancy as possible. They would occur once per trimester thereafter. Then we would have screening at kind of that immediate childbirth period. So before an individual's leaving the hospital with their new baby, we would give them some information about perinatal mental health disorders and tell them what signs and symptoms to look out for, that sort of thing. And then moving into the postpartum period, we would have screening occurring within 3 weeks postpartum, just to make sure that things are progressing well. By that point, we know that the baby blues, so those kind of normal fluctuations in mood, should have subsided. And so if we see persistent mental health challenges in that time, we know that might be time to connect to resources. And then moving throughout the first year postpartum, we ended up suggesting that screening should occur at all well child visits throughout that first year. So the American Academy of Pediatrics already recommend screening at certain of those time points, and we just kind of expanded it and said, hey, the parent is already going to be in the office. Why not do a quick little screen to check in and see how things are going? And so, as I said, starting in pregnancy and going all the way up until that first year postpartum, we have those 13 checkpoints, and we acknowledge that that is a lot. But we thought it was really important to set something like that up so that screening and conversations around mental health become more and more normal. Parents know what to expect when they go to the office. Hey, my doctor's going to ask me how I've been feeling. I'm okay with that. If I want to share, I can. If I don't want to, I don't have to, that sort of thing. And we also understand that there's a bit of flexibility for providers when it comes to screening. So we laid out these 13 time points for screening to occur, but individual practitioners can kind of make educated choices for their own practice and for their patients and decide when they would like to screen within that kind of framework. So that was the product of kind of phase one of this perinatal mental health screening project. Figured out the when, at least when in an ideal world. So something else that came out of the screening project is a lot of conversations about barriers to screening. So forgot to mention that in putting together the perinatal mental health screening timeline, we also spoke to over 150 individuals in different focus groups, because we really wanted to get people's insight and advice on how to put together that framework. So we ended up speaking to obstetricians, midwives, doulas, community healthcare workers, and we also had specific focus groups for communities of color that we know are at higher risk. So Black women, it was a big one. We also spoke with Latinx community and American Indian and Alaskan Native populations. They each had their own specific focus group, which was really great. And so in talking to all of these people, what we got back was a lot of conversation about barriers to screening. People were like, hey, we love this. We want to see screening happen 13 million times throughout pregnancy and postpartum period. But here's about 700 things that will make that near impossible. And we expected that feedback. We knew we were going to hear it and we wanted to hear it. And so what we did is we gathered all of their thoughts, kind of synthesized it, and figured out what we saw as some of the biggest barriers to screening. So I'm just going to walk through those 4 things right now. So number 1 would be, and these are in no particular order, but one of the first barriers was education and training for providers. We kept hearing people say, like even the providers saying, you know, I want to help my patients, but I don't know kind of in-depth information about perinatal mental health disorders. It's not my specialty. I don't have that background. If I'm to be prescribing medication, I don't quite feel confident in, my ability to do that, et cetera, et cetera. And on the other side, we heard patients saying, I didn't feel comfortable talking to my provider about it because I didn't know what kind of information I would get back, that sort of thing. So something that's really, really important is figuring out how to embed perinatal mental health education into our medical education, making sure that OBs, midwives, everybody who's going to come in contact with a pregnant or postpartum person knows about these disorders and it knows the basics of how to treat them or what resources they can provide to their patients to, help them get help. We just think, that's something that's so important. We just want everyone to know about these conditions and know that they have agency to do something about them as well. So that's our first focus area, is that training and education piece. The next focus area or barrier that we heard about was resources. So once again, we talked to our OBs and everyone was saying, I would love to screen, but I am sometimes reluctant to do so because I don't know how to help my patients on the other side of that. I don't know what resources are available, or I don't know what affordable resources are available, because we know that, psychological or psychiatric care can be super expensive, hundreds of dollars an hour just to speak to someone about what you're going through. And not everyone can afford that. So we saw this huge issue with the cliff once again of, people get screened potentially, but then when it comes time for them to actually get resources, it's like, you fall off the cliff, you're left on your own essentially. And we just didn't want to see that keep happening. So we are really focused on one, wanting to identify existing resources and make sure that people are aware of them, that our families, first and foremost, are aware of the resources that they have, and that providers are aware of the resources that they can use or pass along to their patients for them to help. Something that's super, super important. And so we'd like to do some additional research on, how to make those resources more available, and also how to figure out what new resources we need to make sure that people are getting access to treatment. One of the next barriers that we heard about was reimbursement. And this was a big beast of an issue. It was and is. So what we heard from providers is that, it's not easy to get paid for doing these screenings. It takes a lot of time. If you have someone come to your office who's positive and now you have to counsel them and connect them to resources, it can be time and resource intensive. And yet there's no guarantee that you're going to be adequately reimbursed for that. We know that reimbursement for screening varies from state to state, from insurance plan to insurance plan. There's no clear-cut kind of cost breakdown for what that means. And so providers are feeling a little, uncertain or unsteady in that space, knowing that the reimbursement is not where it should be. And obviously that's an issue that is pervasive in all of medical care, but specifically when it comes to mental health, um, issues of reimbursement and payment are a really big deal. So moving forward, we really like to go down and do some research on what exactly the pain points are for providers when it comes to reimbursement. What's, are there coding issues? Is it just that, you're not satisfied with the amount of reimbursement that's coming out of it? There's also, thinking about obstetric care and how it's typically bundled into a global fee. What can we do to kind of incentivize screening under that structure where everything is kind of into one payment? So lots of fun things to figure out there. And we're wanting to do some work in that space for sure. And lastly, one of the big barriers to screening that we heard about in our project was the screening tools that currently exist. So there's an abundance of screening tools for different mental health disorders. Probably the gold standard in the perinatal mental health space is the Edinburgh Postnatal Depression Scale, which is a great tool. It's been very useful to us. But we noticed a few things with that tool in that it may not always be universally understood to different populations. It doesn't quite include any metrics to account for different presentations of mental illness in different populations. So, for example, something that we learned about with Black women in particular is that your mental health conditions may not present in the typical way, but they might be kind of shown as somatic symptoms of, I just can't get enough sleep. I feel tired. My body is sore. My blood pressure is all over the place, et cetera, et cetera. And it can be difficult for a screening tool to pick up on those things. We acknowledge that, that's really hard to do. But we started to think to ourselves and hear from other people, wouldn't it be useful if we tried to, take a look at the screening tools and see if there's any way we can adapt them to be more applicable to diverse populations. And then also another piece of that is making sure that the language that is used in these tools is universally understood as well. So again, not to pick on the EPDS, I think it's a fabulous tool. But we did hear a few people say, there's a question on that screening tool. I think it's question number 6 that says, quote, things are getting on top of me. And we heard patients and providers say, I didn't really know what that meant. So I just said no, or I said yes, or, there's a little bit of a misunderstanding there that just shows us that maybe we can do some work to kind of fine tune these tools and make them so that they're a little bit more effective. Obviously, that is a huge project that's not going to be solved for but it's definitely worth looking into and just seeing, the EPDS is some decades old now. So thinking through, are there existing tools that we could kind of adapt or create that are more easily understood and applicable to our population? So those are the 4 major barriers that we identified through our screening project. And so now we are moving into phase 2 of this project, where we will be drilling down on each of those 4 areas and trying to innovate solutions within what we can do. So we're still in the planning phases of all of that, but we're making some good progress so far. So for example, on the screening tools front, we've actually identified a few individuals who are working in academia who are interested in taking on a huge research project to see if we can develop some new tools or adapt the tools that we have to be a bit more culturally, racially, ethnically sensitive, or to pick up on different presentations of mental distress, that sort of thing. So don't have any full details on that to share now, but we're so excited that we were able to identify those individuals and hoping to support them in that research in any way we can at the Alliance. We've also made some headway in our reimbursement space. So identified a few individuals that we're going to bring into a working group and these are individuals that work for big insurance plans, who are just, expert in reimbursement space, that sort of thing. We really just want to bring them together so that they can tell us what the pain points are when it comes to reimbursement. And we can kind of lay out a research agenda to figure out where to go next with these. So we're making good strides with the next phase of the screening project. And though it doesn't have a full laid out plan right now, I can assure you that it's going to be a great experience. And if you'd like to stay up to date with what we're doing with the project, you can visit our website. It's just mmhla.org, and join our newsletter so that any updates we have, or if we ever need, people to participate in focus groups, I'm sure many of you in the room would be great people to have on our side and having, giving us feedback. So stay up to date with us with that. And then I guess I have a few more minutes here. Again, sorry that the presentation didn't go quite as planned, but now I just want to speak about how you all can get involved with some of this work and what you can do to help the cause for screening in your own individual work. So number one, as I was saying, stay up to date with the screening project, and you'll hear more about what we at the Alliance are doing to move the ball forward and on this. But we also have a ton of resources that we love to share. So that's something that we kind of see ourselves as a clearinghouse of information. So if you visit our website, we have fact sheets, we have resources, we have all kinds of stuff that you all can rely on in your work as advocates or practitioners, whoever you are, that you can use. So some of the resources that we like to plug: number one, the National Maternal Mental Health Hotline that was launched on Mother's Day of last year. We did a lot of advocacy work on the back end of that to lobby for funding to get that hotline up and working, and we're so happy that we finally saw that come into fruition. So that hotline is available 24/7, and it is staffed by the Postpartum Support International. They are the ones that operate that hotline. So feel free. I don't have the number. It is, well, you can put it in the chat, but it's 1-833-943-5746. 1-833-943-5746. And that is a 24-hour hotline that anybody who's in need of assistance can use. So we really like to make sure that people are becoming aware of that hotline. Let me see what else I want to share here. As I mentioned, Postpartum Support International, I'm sure many of you are familiar with their work. Amazing resource. You can visit their website and kind of, find whatever resources you need. They've got things for providers, but also for individuals that are experiencing perinatal mental health disorders to access support groups. They also have a helpline, a warm line that's still operating that can help people get hooked up to resources. So super important. On the provider front, Postpartum Support International, again, but we also know that there are psychiatry access programs across the United States where providers, obstetricians, clinicians can get kind of real-time consultation help if they are, wanting to figure out what resources or medications to give a patient. That helpline is really amazing, and it kind of helps us fill the gaps in the meantime until we can make it so that everybody knows about perinatal mental health and how to treat them. Those consult lines really fill the gaps and make it so that there's always a way to find help if you're looking to help a patient. And then there are also several toolkits for providers. ACOG has one, the American Academy of Pediatrics has one, same with American Academy of Family Physicians has toolkits that are really useful for providers in figuring out how to treat these disorders. And there are also some professional learning opportunities that I can't dig into right now. But if you are looking for continuing education in the space of perinatal mental health, there are many options. And so I will stop there and just direct you all to the MMHLA website if you're looking to learn more about these resources, and also be sure to share the slides. But thank you all so much for listening and bearing with me through the technical difficulties. Maybe in the future you'll cross paths with me again and I can give you a full, robust presentation of the screening project. But it's been so lovely to speak with you all.
Thank you, Aminat.
Thank you.
I know you can only see like the first row. Obviously, no one likes to sit in the front row, but
Yeah.
there's a lot of people behind us. So, just a quick question, a quick raise of hand. Has anybody heard of the Maternal Mental Health Leadership Alliance prior to this presentation? So you've educated a number of people on your organization who now have an additional resource and tool in their tool belt regarding maternal mental health. So we appreciate you. Again, apologies on our end as well for the technology difficulties, but after the conference, we'll provide wrap up and contact information as well. Feel free to reach out, and we appreciate your time.
Awesome. It's been great talking to you all. And if you want to reach out, my email address is just my first letter A and then my last name at mmhla.org. And I would love to hear from any and all of you. So I hope you all have a great